Okay, let me pull up my screen. All right.
All right. Just gonna wait like one more minute just to let final people join in. All right, so it is 12 on the dot, so we're going to go ahead and get started. So I just wanted to take a moment and welcome everyone. Thank you so much for joining us today. My name is Kimberly Mankus, and I am a health educator at the Maxwell and Eleanor Blum Patient Family and Learning Center here at Mass General Hospital. Today is a special collaboration between the Blum Center and the Cancer Center.
Hi everyone, my name is Mariam Daib, and I'm also a health educator here at the Blum Center. And before we get started, I just wanted to go over a few things. Please note this session is being recorded for educational purposes. If you are interested in viewing this recording, it will be made available on the Blum Center website at massgeneral.org/blumcenter. You are in listen-only mode. Everyone has been muted to eliminate background noise so that we can hear the speaker. If you have a question, please use the chat feature at the bottom of your screen. Only Blum Center staff, the co-hosts, and the guest speaker will see your questions. We will have time at the end of the session for them. Please do not share any personal medical information or questions in the chat. If you have a medical question, please ask your doctor.
So next, I'd like to introduce you all to Devin Punch. She is the health educator for the Mass General Cancer Center, and she is now going to introduce you to today's guest speaker.
Thank you. Thank you, Kim and Mariam, and welcome everyone today. Thank you for joining us. I'd like to introduce Stephanie Hicks now. Ms. Hicks joined the Center for Cancer Risk Assessment in 2017. After graduating from the University of Colorado with a master's in genetic counseling. As a part of the center, Ms. Hicks provided risk assessment and genetic counseling services in both the breast, ovarian, and GI cancer clinics, both in Boston and in Amherst. In addition, she also sees patients in the neuro-oncology genetics clinic. And Stephanie, thank you for being here. I'll turn it over to you.
Thank you so much. Let's see if I can share my screen successfully. What is happening here? Sorry about that. Oh no, already messing up. Thank you so much for hosting this series. I know my colleagues and I really appreciate the Blum Center giving us an opportunity to expose what genetic counseling is, especially in the context of cancer genetics. So I'm happy that we are able to present this series, and me specifically to talk about Cancer Genetics 101 and basically go through the timeline from past to present, how it's changed over time. So just to go briefly through an agenda of what I wanted to go through today. First, I did want to give everyone an overview about what genetic counseling is. As I mentioned, a lot of people have never heard of genetic counseling, at least that's my experience. So I wanted to present what we do, at least in the clinical setting, and more specifically, where cancer genetic counselors are involved in the cancer setting. I want to present what cancer genetic testing is and explain why different genes are associated with hereditary cancer risk. We'll go through a case to discuss historic cancer genetic testing and how this has changed over time. This will ultimately lead to the most up-to-date genetic testing options. And at the very end, I did want to compare direct-to-consumer testing. We get this question a lot, 23andMe, Ancestry, compared to the genetic testing that's ordered by healthcare providers. So to start, what a genetic counselor is, it's helpful to pull the definition of what genetic counseling is from our national society. And I'll just read it to you that genetic counselors are professionals who have specialized education in genetics and counseling to provide personalized health or genetic counseling to help patients that may need to make decisions about their genetic health. Today, there are about 5,000 certified genetic counselors, at least that's the number we have pulled from our national society. In contrast, the first graduating class was in 1971, and it was a class of 8. So we've grown exponentially as a field in about 50 years. In the clinic setting, we help to facilitate informed choices about genetic testing. We help people understand and adapt to the medical, psychological, and familial implications of their genetic contributions to their health. We interpret family and medical histories to assess the chance of occurrence or recurrence of a syndrome or a disease in that person's family. We provide education about inheritance, testing options, medical management implications. We'll discuss screening and prevention if it would influence medical management. We can identify support and resources, and also if people are interested in research, we can help with that. And obviously, if someone is positive or we find something, well, when a patient pursues genetic testing, we also provide post-test counseling to help that individual and their families incorporate this genetic information into their healthcare picture. So more specifically, where are genetic counselors involved in clinic? And this is a very broad overview. I just wanted to put that plug in that genetic counselors are involved in a lot of different clinic settings. And I just wanted to do kind of a very brief overview in 3 main areas. One is in the prenatal setting. People or couples may want to discuss the possibility of their first child to have a genetic condition. Maybe that's based on their family history or maybe their personal health history. Subsequently, couples may want to discuss the risks of having subsequent children, of having a genetic condition that one of their current children has. In the pediatric setting, we may evaluate a child who is not developing typically. We may evaluate a child who may not be processing foods or nutrients typically. And then there's also a subset of obviously children developing cancer. That's obviously kind of our area of expertise, a little bit of overlap with pediatric and cancer genetics. Mainly today's talk will be focused on adult cancer genetics, but pediatric cancer patients are seen by us as well. And then last but not least, in the adult setting, someone has an undiagnosed health concern and they wanted to know, is this related to my genetics, something that could be passed down to my family or maybe has implications for my health moving forward. Some of these genetic syndromes that are identified in the pediatric setting have lifelong implications, and they need to be monitored by an expert that knows what it means for that person to have that genetic condition. And last but not least, what you're here for today is to talk about hereditary cancer predisposition, specifically in the adult setting today. What do cancer genetic counseling, what do we do in a day in clinic? So the first question to answer is, who do we see? So we may be seeing people that are newly diagnosed with cancer. Maybe they were younger than 50, or maybe they were diagnosed with a rare type of cancer. Maybe someone has a personal history of cancer and they want to know, what's the likelihood that I'll develop a second cancer in my lifetime, or implications for my family members. Someone may be unaffected. They've never had cancer, but they have a striking family history of cancer. So they want to talk about this potentially being hereditary and implications for themselves and their families. I already briefly mentioned this. Rare types of cancer, we always get a little more concerned about being that, rare types of cancer happen more rarely. So there may be an underlying genetic condition that is, predisposing that person to developing that cancer. And then we also have specialty clinics. As my bio said, my specialty is neuro-oncology. The pediatric oncology is also specialty clinic. We have many specialty clinics we'll see patients in where the genetic syndrome has other features in addition to the cancer or tumor predisposition. What do we do in clinic? So first and foremost, we provide a risk assessment. So first, we'll basically take a family history to review that patient's personal health history, whether that they have cancer or not, and also take a family tree focusing on cancers and tumors. And that risk assessment is basically having a conversation about what patterns we can see in the family or patterns that we can't see in the family that make us more or less suspicious that there's something hereditary being passed down in the family. That also guides our conversation about what genetic testing options are. Sometimes people that we evaluate saying they're pretty low risk are still super motivated to pursue genetic testing. And, we can always be surprised. You can never say never in genetics, even though someone's not, a family doesn't seem super striking, there still could be something there. Or maybe there is a very strong indication for something hereditary. So we would want to discuss genetic testing options. And then, last but not least, the implications of doing genetic testing. If they're negative, what does that mean? If they're positive, what would that mean for them moving forward? So that's another discussion that we have even before they decide they want to do testing. So basically that first discussion is really deciding, is genetic testing right for you? And what would this mean for you moving forward, no matter what the results are? So generally around this point, people ask, so what do people do with this information? Why would they want to know? So I generally say the genetic testing can potentially accomplish 3 goals. It could change how that person is monitored by their doctors. If a person is unaffected, maybe we find out they have an increased risk for breast cancer or colon cancer, and maybe they wouldn't have known that and maybe not started screening until someone in the general population, age 40 or 50, and they actually should start earlier. Or they may find out if someone's already diagnosed with cancer, we may find out about other cancer risks, maybe cancers that we haven't seen in that patient or in the family, but we know are associated with that particular gene. And what would that mean for that person moving forward as far as monitoring for that cancer? And then the last point would be, who else is at risk in my family? If we can identify a specific reason why there's cancer happening in a family, we can then test on other family members to say, are you at this increased risk of developing cancer? Or if they test negative, we can basically take that risk off the table for them and adjust their lifetime risk of developing cancer. So, the main part of the talk today is to discuss what has changed over time, but I think it's important to also review what hasn't changed, because these are kind of gives us more context to talk about what genetic testing is. So the 4 main things I wanted to review before we jump into what has changed over time are how genes are inherited. So we'll talk about how genes are passed down in a family, what a gene mutation is. That's important to know what that is. How cancer forms from a genetic standpoint. And then what genes are we talking about that are associated with hereditary cancer risk? So those are the 4 things I wanted to go over before we dove into what's changed. So the first question to answer are, what are genes? Basically, genes are our body's instruction manuals that allow our cells and therefore our bodies to grow and function properly. Our genes are made up of their own specific alphabet of A's, T's, G's, and C's, and these are just kind of template. I typed this in, so these are not sequences. Do not try to Google this. So this is just what a gene sequence could potentially look like. And they're supposed to be spelled a certain way for the cell in our bodies to grow and function properly. So what are mutations, if we know what a gene is now? A mutation is basically a spelling mistake, excuse me, in that gene's sequence. So, we expect our genes to be spelled a certain way for them to function properly. I've represented 2 different types of gene mutations or spelling mistakes that can occur in a gene. There are many different types of mutations, but just for the purposes of this talk, I just wanted to give 2 main examples. One would be a point mutation or a single letter change. So that just to orient you to how you read this, there's supposed to be an A at this specific line, and it was replaced with a T. And that may not seem like much when we're thinking about this gene being thousands and thousands of letters long, but it can have a pretty significant impact on the function of the gene and maybe influence how that gene is read, subsequently after that 1 point mutation. And then the other box I tried to represent here is a deletion. So basically, part of the gene is missing. There's supposed to be an ACC here, and it's just completely gone. And again, that can have implications of the gene being read properly. So now that we know what genes are and what a mutation is, I wanted to go over how genes are inherited. So we get all of our genetics from our parents. All of us are born with about 20,000 genes, and we get one copy from mom and one copy from dad. So we actually have two complete sets of that 20,000 genes. So if we're narrowing in on one single gene, so each of these bars is just, this is one gene, two copies of each in both parents. Each offspring has a 1 in 4 chance of having, a particular combination. So they may have, this combination, this combination, this combination, and this combination. So 1 in 4 chance of, getting one copy or the other in a certain pattern. So what happens if a parent has a mutation? And for our purposes, we're talking about an autosomal dominant pattern of inheritance, which basically means that if a parent has a mutation in one copy of the gene, they can pass that down to their child, and their child would be affected. So autosomal dominant means two different things, meaning that they only need one mutation in one of the copies to be affected by the condition, in this case, be predisposed to developing cancer. And it means that the child would only have to inherit one mutation from one parent to also be affected. So visually, I'm a very visual person, so bear with me if you're not. So visually, if we're taking, just focusing on one parent, they have a 50% chance of passing on one copy and a 50% chance of passing on the other copy of this particular gene. So similarly, if they have a mutation in one of these copies, they have a 50% chance of passing down the predisposition or the mutation to their child, and then a 50% chance of passing on the working copy that doesn't have the mutation. So this child would be unaffected, not have the hereditary cancer predisposition, and this child would have the hereditary cancer predisposition or be affected. So now that we know what genes are, what a mutation is, and how they're inherited, I wanted to talk about what cancer genes are. So going back to, we all start with 20,000 genes. In theory, have two complete sets of 20,000 genes. We're actually looking at a smaller subset of genes that control cell growth, and science has found about 400 to 500 genes regulate cell growth in one way or another. And then, an even smaller number of the 400 to 500, 60 to 100 of those genes, science has proven that there's a known hereditary predisposition to cancer in 60 to 100 genes. So we're talking about a really small group of genes when we're talking about hereditary cancer testing. So why does cell growth matter? So in the context of cancer tumor development, that's really just the overgrowth of cells. So we're supposed to have this complete set of instruction manuals that are supposed to regulate cell growth, so we don't have an overgrowth of cells. And if we no longer have those instructions to regulate cell growth, a cancer or tumor is more likely to form. So visually, if we're talking about a cancer that just happens by chance, someone that doesn't have a hereditary cancer predisposition, we're talking about someone that's born with a complete set of those genes that regulate cell growth. And then over time, maybe in the breast tissue or prostate tissue, a subset of cells accumulates a mutation or one of those spelling mistakes in one of these growth regulating genes. It's okay, we still have a bunch of other ones, but that gene, that group of cell may be more predisposed to accumulating a second mutation. And that's exactly what happens in the progression of cancer. So a second mutation in another gene that regulates cell growth is accumulated over time. So now this cell is even more likely to, not listen, overgrow. And then a third mutation is acquired in an even smaller subset of cells. Now you can see the cell no longer has normal morphology, which is actually really important in cell growth and regulation. Our cells are supposed to be shaped a certain way, and when they touch each other, they're supposed to stop growing. So when the cells are atypically shaped, they no longer have those instructions to stop growing when they touch each other. So then a fourth, a fifth, a sixth mutation is acquired in one cell, and that cell has no instructions saying, hey, let's slow down, let's not over proliferate or over divide. And that's really how cancer forms. So this is what typically happens in about 90% of cancers. There's this happens sporadically or just by chance. This is something that's acquired over time and just a subset of cells. So when we talk about hereditary cancer predisposition, we're trying to figure out if we're talking about in the context of someone that's had cancer, did that cancer happen sporadically or just happen by chance? And again, this is just acquired mutations over time, not something someone was born with. Or was that person born with a spelling mistake or a mutation in one of those genes that, you know, regulates cell growth? So every single cell of their body has this mutation, and that person's more likely to develop cancer over time. There's a lot of information. We haven't even gotten to the timeline yet, but now that we've talked about what hasn't changed in cancer genetics over time, I wanted to discuss how far we've come in clinical testing for hereditary cancer predisposition. And this is kind of the breakdown of timeline that I wanted to go through, but I'm going to use a case to kind of represent these. So you'll see these blocks brought up throughout the rest of my talk. So we'll talk about certain ranges of time while we're going through this case. So how has this timeline affected clinical testing over time? So I hope this is a helpful way to review this. We're going to go through Jane Doe's experience with cancer genetics, and she's going to revisit us a couple of times because of improvements or changes in clinical genetic testing. So Jane Doe came to us in 1998 at 28. She wanted to talk to someone in cancer genetics, a genetic counselor in cancer genetics, because her mother was just diagnosed and then quickly passed of ovarian cancer. And she wants to know what's her risk of developing ovarian cancer or just cancer in her lifetime. So the first thing we do is we take a family history to provide risk assessment. So just to orient people who maybe aren't as familiar with family trees, we call these pedigrees. So they're really family trees focused on cancers and tumors. We use circles for females and squares for males. We draw the arrow to our patient. So this is Jane Doe here. This line, when people are connected by, you know, a horizontal line and then lines going down, mean they're siblings. So she has one brother. This line going up means these are this patient's parents or the person's parents. So the circle is her mother as a female, and the color means she has ovarian cancer. I apologize, the text is super tiny. And then mother has a brother, and then basically, hopefully that makes sense. So, and then moving up over time. So when we took the family history, we saw that mom had ovarian cancer at 46, a younger age. And even when we say, you know, in general, anyone diagnosed with cancer under age 50 is considered early onset. So not only a rare type of cancer, but an early onset cancer. And then her grandmother also had breast cancer, passed away at 70, but she didn't know what age of onset she was diagnosed with breast cancer. So we go with what you know. If you know she had cancer, that's still super helpful. So in 1998, what did we have to offer Jane Doe? So we had either single gene or single syndrome testing in this range between 1996 and 2006. So what could Jane Doe get tested for? So with single gene or single syndrome testing in 1998 or between this date range, we really only had, you know, two particular syndromes, you know, main syndromes that we would talk about. We'd talk about hereditary breast and ovarian cancer syndrome, or HBOC, and the cancer risks that go along with it are breast cancer and ovarian cancer. Now, that sounds similar to what we're seeing in her family. And for genes that we have to test for that, we have the infamous BRCA1 and BRCA2 genes, or the BRCA genes. A lot of people have heard of them before. And then, you know, just as common, but people haven't heard as much, is we also have Lynch syndrome. With the cancer risks that go along with Lynch syndrome are colon cancer and uterine cancer. And the genes that go along with Lynch syndrome, there are 5 different genes. I won't read through those because it takes a bit. So we basically had, you know, people took a family history and said, what bucket do you fall in best? So, you know, when we look at those cancers and we think about her history, we say she has ovarian cancer and breast cancer in her family. This seems like a pretty good fit. So what are the concerns? So just to give you a little background, in 1996, Myriad Genetics patented the BRCA1 and BRCA2 gene sequences, and they started offering clinical testing for individuals and families with a personal and family history of breast and ovarian cancer. But so the two caveats is that it turns out sensitivity of genetic testing technology was not comprehensive. We'll go over what that means in a minute. And the cost of genetic testing was a huge issue. So testing ended up being very expensive and often not covered by insurance. And this was a huge barrier for a lot of families that, you know, we clinically would like to have testing done for that family based on what we're seeing in the family. They would benefit from that. So just taking a little step back and talking about what sensitivity of testing is. So there are two main ways, that's very generalized, that we talk about, looking at a particular gene. There's many other ways. For the purposes of this talk, we're talking about two different ways of looking at the gene. So there's sequencing of the gene, which is basically checking the spelling of every single letter. So what they do, you don't really have to understand what this is. I'm a nerd. I like looking at these things. So basically we have this templated, we expect the gene to be spelled a certain way, and they look at every single letter of the patient's DNA and compare it, run it out on a gel and say, is this interrupting the function of the gene from a spelling standpoint, or, is this spelled as we expect? And then there's also deletion and duplication analysis, which is basically checking the word count of the genes. So not that our genes read like this, but using this sentence as an example, the dog ran through the field. So maybe there's a deletion of a couple of letters in the gene. So, if there's a deletion here, then the rest of the sentence just doesn't make sense at all. It's all gobbledygook. And then, or maybe there's a whole word deleted. So the gene kind of makes sense, but it still is hard to read. So it's basically, not functioning properly. So between 1996 and 2006, we only had sequencing available to our patients. So we really knew we weren't testing, we couldn't really offer them comprehensive testing of genetic testing, because we were only looking at the sequence of the gene. So there was, potentially deletions and duplications that were missed by just doing sequencing. Jane Doe was consented to this. She knew this. She was still super motivated to do testing. So she consented to do BRCA1 and BRCA2 testing. Luckily, the genetic counselor was able to get genetic testing covered by her insurance after a month-long correspondence. This is not something I personally dealt with, but something that I've heard my colleagues, more experienced colleagues, experience that, it was a pretty much full-time job working to get this covered by their insurance. So luckily, Jane Doe got it covered by her insurance. And unfortunately, I shouldn't say unfortunately, she was negative. So she has negative BRCA1 and BRCA2 sequencing, which is somewhat reassuring, meaning she doesn't, we haven't proven she has a predisposition to developing these cancers, but she also has this concerning family history that's currently unexplained. So it's kind of uninformative. So 10 years later, Jane Doe, the year is 2008, if you wanted that. Can't do a quick match. She reached out to the genetic counselor and asked if there was any updated testing. So we always tell our patients, definitely contact us periodically, and we will attempt to contact you as well when there are updates to genetic testing. So at this, something triggered Jane Doe to call her genetic counselor and ask about any updates to genetic testing, either technology or options. So the genetic counselor asked her to come in. So between 2006 and 2013, there were improvements in gene coverage sensitivity. So going back to testing technology or sensitivity, we now could offer clinical deletion duplication analysis to these patients. So she technically could have more comprehensive coverage of the BRCA1 and BRCA2 genes. Unfortunately, her insurance had not changed, so Jane Doe did have to pay for the deletion and duplication analysis out of pocket, which is, we're talking in the realm of a couple $1,000s or maybe about $1,000. So that's a lot of money. Jane Doe still wanted it done. She's super motivated to do testing. And she still was negative. So now we know that she's negative for the sequencing of BRCA1 and BRCA2, and she also is negative for deletion and duplication analysis. We're still back to, we have this concerning family history. We still don't have a genetic explanation. We're limited as far as our knowledge of what we can offer her and what we know about hereditary cancer. Jane Doe came back in 2020, early 2020, because her cousin had recently passed of ovarian cancer. This was a prompt for her to recontact her genetic counselor. And now there's a lot to discuss with Jane about what updates we have to hereditary cancer testing. Multi-gene panels, we'll talk about that in other testing labs. So in 2013, the United States Supreme Court determined that it was not legal to patent something that occurs naturally in nature, like a DNA sequence. So Myriad Genetics no longer could have the patent on the BRCA1 and BRCA2 genes, and now other genetic testing labs could offer testing for these genes. So more competition means more competitive pricing. And just to give you a general overview about, the pricing historically to now, it used to be thousands of dollars. I still hear people quote, is it going to be $4,000 or $5,000? And that's not the case anymore. About, 7 to 10 years ago, the price was reduced to, between $500 and $900. Still a big bill, but nothing near $4,000 to $5,000. And today, the self-pay price for this genetic testing is between $249 and $350. Now, still an out-of-pocket cost, still potentially inhibitive of people doing genetic testing, but definitely more accessible to a decent amount of patients. So we're getting there for more accessibility cost-wise. The other thing is that we've now discovered more genes associated with hereditary cancer risk. So going back to that word panel, you don't need to memorize this. Again, I'm a visual person. I really like these charts. I show this to all of my patients. We now look at a family history and say, what category do you fall into? Do you fall, do you have most, cancers in your family are breast and gynecological related? Do you have GI related cancers, maybe GU or kidney, bladder related? We know of a lot of genes associated with hereditary cancer risk. And we know we basically offer these in panels, or we group them together by cancers that we're seeing in the family. The other thing that I like about this chart is it demonstrates there's a lot of overlap in knowledge now. So we kind of already demonstrated this with Lynch syndrome and with HBOC, that, these genes are associated with not just, breast and GYN cancers, but also maybe other types of cancers that haven't manifested themselves in the family yet. So with the introduction of multi-cancer panels, we really went from single syndrome testing, HBOC, Lynch syndrome. We could still offer that to patients, but I always get nervous because, we know now that's really not comprehensive testing for that patient or their family. So generally the conversation is more focused around cancer focused panels. So maybe there's just breast cancer in the family. So we pick and choose the breast cancer genes. Maybe colon or ovarian is prominent in that family. So maybe that patient wants to talk about colon cancer genes or ovarian cancer genes. And then there is the option of doing multi-cancer panels. And generally, these multi-cancer panels fall into two categories with our testing labs. They either fall into a common cancer panel, which is basically looking at the most common cancers, basically the 10 top cancers that manifest themselves in the country or in the world, and they pull all of those genes associated with those cancers. So basically cancers you've heard of before. Or, some people want to test for every gene that we can offer for them clinically, and that's all known hereditary cancer predisposition. So the conversation is really about how much information do you want to potentially learn about yourself, rather than, more about the limitations of doing testing. So going through all of these updates, Jane Doe is super interested in testing really broadly. She looked at 85 different genes with her testing. And it turns out she has a BRCA1 gene mutation and a HOXB13 gene mutation. Now, I don't expect anyone to know what that means, except maybe any genetic counselors in my group on the call. But basically, BRCA1 is associated with hereditary ovarian cancer. So, I'd be super suspicious that this probably came from mom's side of the family. We can't test mom, but we can test dad or other family members on mom's side of the family to say, if we can prove it comes from one side of the family, then we can definitely make mom, we know that came from mom based on how we know how genes are inherited. And HOXB13 is one of these incidental findings. So she wouldn't have found this based on just looking at ovarian cancer genes. HOXB13 is actually associated with prostate cancer. Now, she doesn't have a prostate, but her sons do, and all of the men in her family do. So this is kind of, we would say, an incidental finding, but definitely helpful for her family moving forward, so we can, know more what their hereditary cancer risk is, and we can monitor them appropriately based on that. So the first person that does testing is her maternal uncle. He also has the same test results as Jane. He has the BRCA1 gene mutation, and he also has the HOXB13 gene mutation. As a man, he doesn't have ovaries, so he doesn't really need to do anything related to the BRCA1 gene mutation, but when he knows, he could have passed that down to his son and his daughter. And the HOXB13 gene mutation, again, kind of a surprise, but he does have a prostate, so now we know we need to monitor him more closely for prostate cancer development, rather than, just the standard prostate cancer screening for a 74-year-old. So the next person that does testing is her brother. He is a true negative for this BRCA1 gene mutation, so meaning that he did not inherit this. Just to back up a little bit, because we now have proven both of these mutations come from mom's side of the family, we would call mom an obligate carrier, meaning we can't test her, but we know that if this relative related to through mother, now related to uncle, both carry the same mutation, we know that had to have been inherited from mom's side of the family, so through mom. So for her brother, back to her brother, true negative, meaning his daughter does not have to worry about the hereditary risk for ovarian cancer. And he does now know that he has an increased risk for prostate cancer. So he would, again, be monitored more closely for prostate cancer development compared to, maybe other 44-year-olds don't get checked as often as he would. And then the last person in the family was the maternal cousin, the brother of the cousin that had ovarian cancer. And he is a true negative for both the BRCA1 gene mutation and the HOXB13 gene mutation. And that means a couple different things. It means that his son and his daughter do not have to worry about inheriting either of these hereditary cancer risks from this side of the family. And it also means that he does not have to worry about the hereditary prostate cancer risk. He can follow general medical management guidelines for men in their 40s for prostate cancer. So really the take-homes are that the conversation has shifted greatly over time. So historically, we would talk about single gene or single syndrome, and we'd really spend a lot of time about the limitations of that. There's uncertainty with a positive. What do I do with this information? That evolves over time. So when you're doing testing really early on, we may learn about more cancer risks or learn how to monitor that person over time rather than basically the knowledge is going to change over time. With a negative genetic test results, it's a little uninformative because there probably is something else that we don't know to test for yet. And then the cost of the genetic testing and insurance coverage was a big issue. We had a limited scope of what insurance would cover. So it would be really hard and difficult to get someone to get covered by insurance. And if they wanted to self-pay, it would be in the realm of $4,000 to $5,000, which is a lot. I know I don't have that laying around for genetic testing, so I know a lot of our patients found that pretty inhibitive of doing testing. So present, the conversation is more about how much information do you possibly want to get from this testing. We can do more targeted testing, or we can do super broad, like our patient Jane Doe did. And the other, big conversation is incidental findings. Similar to Jane Doe, we had no idea or no indication to test for prostate cancer genes, but it happened to be in the family. So now we know that there's hereditary prostate cancer risk in her family. That's more of an incidental finding. The cost and insurance coverage, there's two things. The prices have been greatly reduced from $4,000 to $5,000 to in the realm of a couple $100s. And the criteria to cover genetic testing, and it's a lot easier to get insurance to cover genetic testing now than it was historically. And the other conversation is more, what do we do with this information? That hasn't changed too much over time, but we know more about these genes, so we have kind of a better understanding of some of these genes. So medical management implications. So this is a big conversation I have with my patients. I'm sure my colleagues do as well. We generally put the genes into two buckets. We have genes that have potential medical management implications. That could mean altering screening. Maybe, if we're talking about breast cancer risk, normally women start, annual mammograms or their breast cancer screening at around age 40. So if we know someone has a hereditary breast cancer risk, we may do, mammograms and breast MRIs, or maybe we'll, the other point is introducing surgery. So for ovarian cancer risk, for an example, if we know someone has hereditary ovarian cancer risk, we know that that person, we don't have the mammogram or the colonoscopy for the ovary. There's no validated way to screen for early ovarian cancer. So the way we reduce the risk of developing ovarian cancer is to remove that tissue, so that, it's never can be zero, but greatly reduced from the estimated lifetime risk we would quote them. And that's the other thing. A lot of these genes with medical management implications, we have adjusted lifetime risk, so that we can kind of quote them a range. So maybe we say women in the general population have up to 12% lifetime risk of developing breast cancer, and then someone with a BRCA gene mutation has between a 50 to 75% lifetime risk of developing ovarian cancer. That's what I mean by adjusted lifetime risk. And then we also have a subset of these genes that we call preliminary evidence genes, which basically means there's new data for cancer association. Maybe science, there's 1 or 2 papers published saying this gene tracks with all of the women that have breast cancer in these 15 families. But we don't really know what to do with that information yet. We seem to have this preliminary evidence that it's pointing toward an increased risk for cancer predisposition, but we don't really know, we haven't figured out the best way to monitor that person over time. And we also, may not have good data for an adjusted lifetime risk to quote that patient. We basically say, this may increase your risk for breast cancer or colon cancer, but it's kind of to be determined what that actually means for you moving forward. It's, again, an evolution of knowledge over time, which is true for genes that have medical management implications. It's just going to, be more variable with these preliminary evidence genes. Another thing, kind of shifting gears to other things that we talk about with patients now that we hadn't really thought of historically, is that, can genetic test results be used against us as a pre-existing condition? And the term that we use to kind of define this is genetic discrimination. In 2010, a federal law was put in place called the Genetic Information Non-Discrimination Act, or GINA. And that, by and large, protects us with our health insurance and our employment to discriminate or use this against us as a pre-existing condition if we're positive. There's exceptions to every law. We're not lawyers, but by and large protects us from this for health insurance and employment. Some things you may see missing from that list are life insurance policies, disability policies, and long-term care policies. That basically means that if you're positive and then you decide to monitor a life insurance policy or apply for a new disability policy, they legally could request your genetic test results and use it against you however they see fit. This doesn't mean it's impossible to get these policies, but it could potentially cause issues, or maybe they would charge you more because you're higher risk. And last but not least, we get this question a lot, especially after 2018, that a lot of people ask us, can I just get my cancer genetic testing through 23andMe? Yes, with a ton of caveats. It definitely won't be comprehensive. So in March of 2018, the FDA approved 23andMe to report on 3 specific mutations that are commonly found in the Ashkenazi Jewish population. And now they also are allowed to report 2 common mutations that are found in a gene called MUT-YH. BRCA1 and BRCA2, as we discussed, are associated with breast cancer, ovarian cancer. Definitely not comprehensive for even the sequencing or deletion and duplication analysis of BRCA1 and BRCA2. And again, it's not comprehensive testing for the MUT-YH gene, which a lot of people haven't heard of, but it is associated with hereditary colon cancer risk. So back to visuals, per usual, what are the differences? So what 23andMe would report are 3 specific mutations that are commonly found in this particular DNA sequence, or if we're talking about comprehensively, 5 specific mutations that are found among these 3 different genes. So what it couldn't detect would be, a deletion in this other location, or maybe a point mutation. Anything that's not what they're approved to report out, they cannot report. So it basically means that they wouldn't report mutations in other genes associated with hereditary cancer. They wouldn't even be able to report other mutations in the genes that they weren't already validated to report. And with that, I wanted to thank everyone for attending today and ask if there are any questions. And this is our most up-to-date picture of our awesome genetic counseling team. I say that I'm in that picture, but my colleagues are great. And then the medical co-directors as well. Yeah, and if you have any questions or want a referral, you can give us a call.
Thank you so much, Stephanie, for your informative presentation. We appreciate it. We have time for some questions now. So if anyone has anything they'd like to ask, you can type it into the chat and we'll get to it. We have a couple questions in now. First one, how do you acquire mutations?
Yeah, so acquiring mutations can happen just by aging. Life is a risk factor for developing cancer. So as our cells get older, they get tired and they're more likely to acquire a spelling mistake. These happen when our cells go to replicate, they copy themselves. they have to copy all of those 20,000 genes to make a perfect replica of themselves. So if that cell is tired or older, they're more likely to make a spelling mistake just naturally while they're copying themselves. Other risk factors obviously could be location where you live. It could be, chronic tobacco or alcohol exposure. Anything really that's chronically, that you're chronically exposed to could be a risk factor of acquiring a mutation. Hopefully that answered that person's question.
Thank you. Could you provide the list that contains the genes and associated cancer? That grouping seems very helpful.
Oh,
I think it was the slide that you said that you share with many of your patients. We can that's posted.
This list I compressed for this slide, but I'm happy to pass along these visuals. This one is from a lab that we use often, and then there's another visual from another lab. I'm happy to share that, as long as there's nothing wrong with sharing that.
Sure, if you're able to, can do that afterwards and get it posted on the Blum website. Thank you.
Yeah. Mm-hmm.
So this next question has a couple of questions and thoughts in it. Okay. Why not do whole genome testing, as I would assume that the patient pays for each cancer panel? Would it not be cheaper for them to pay for just one test? We already know that mutations are not always corresponding to a particular cancer. For example, BRCA 1 and 2 are not just associated with breast cancer, but prostate as well. And many therapies are tied to what mutations are found. Some panels may miss particular genes that might be therapeutic, that might provide therapeutic value.
That's a whole, and I'm sorry, the first, they asked about whole genome testing or whole exome testing?
Exome, I'm sorry about that. Yes.
Exome, yeah, no, that's okay. My headphone cut out for a second. So there's a couple different reasons why whole exome is not first line testing. One is that, just to kind of address cost, the cost of doing a whole panel, that 85 gene panel, which is the most comprehensive testing we can offer in the realm of cancer genetics, is that $250. We're not talking about $250 being applied to every single gene. There's a lot of limitations to whole exome. One, the cost of whole exome is going to be $4,000, $5,000, $6,000, $7,000 and is often not covered by insurance. Insurance basically actually wants these tests done, proving that they're negative and that we actually have to explore further and looking for these newer genes that maybe science hasn't discovered yet or is just in the research realm. Turnaround time, if we're talking about therapies for people that have ovarian cancer or pancreatic cancer, they can't wait, 6 months for this testing to get back. Sometimes we can get it back in 3. And the informativeness of testing. So even if we have someone that's had this testing, that's, this testing in exome is negative, we only find a genetic explanation about 25% of the time. And that's in the PD setting where a child is, severely, disabled and has a lot of underlying health concerns. And they're using this to try to find that. So I imagine that number would be lower in cancer genetics. The other reason, sorry, I'm going on a rant here. The other reason would be that a whole exome is just sequencing. It would not detect deletion and duplications. So we could potentially be missing something there. And we'd also be missing the reads. It doesn't read as in depth. It probably does 20 to 50 pass coverage versus this testing does 500 to 1,000 pass coverage. So we potentially could miss a mutation in one of these genes. And last but not least, if you do your whole genome, you're going to find a lot of these variants, every gene is going to be spelled a little bit differently. And ideally, you would compare it to a parent's, you'd actually do this in a trio. So you'd be looking at the sequence of mom, dad, and the patient. So that itself is really hard to coordinate. And if you just did whole exome on a patient, you're going to have a lot of variants and not really know what to do with that information. So there's a lot of reasons why we don't frontline do whole exome. So I apologize that took up a ton of time.
Thank you. We have a couple more questions coming in. Is there an age above which someone would not benefit from genetic counseling and that therefore the onus shifts to the offspring and next generation?
I would say ideally we'd like to test the people that have had cancer, because if there is something hereditary in the family, we would say more likely that the person that's developed cancer would test positive, because we've already seen that cancer manifest itself in that person. So even if the patient is 92, maybe it wouldn't benefit them in the sense that it would change, they probably wouldn't change how they're followed by their doctors. Most, 85 to 95-year-old I've experienced don't want to go in for mammograms and breast MRIs, but they do this for their children. So to provide an informative test result is helpful in the sense that if we can identify why there's cancer in the family, we can do more targeted testing for the offspring of those kids, that patient.
I think I'll jump in because I think there's a bit of technical difficulties.
Okay.
Another question that we have is, how do you, what does it say? Have you had to manage and deal with patients who have come into the clinic with negative results from 23andMe, but then have positive results from the medical grade genetic testing?
Yes, this happens a lot. So going back to, speaking to all of those limitations, a lot of people will say, well, I already had negative 23andMe. I don't need to test for these genes. And that's actually not the case. So as I pointed out, that 23andMe can miss a mutation in the genes that they're approved to report on. So that has happened where that happens a lot of the time, where a patient comes with negative testing. They have a very striking family history, and we find that they have either a mutation in one of the genes somewhere else along the gene that 23andMe reports on, or we find a mutation in another gene that 23andMe legally cannot report on. So that does happen.
We have 2 more questions. What's my average chance of having a genetic mutation that would give me a higher risk of getting cancer?
That's a loaded question. I can't really answer that without seeing the family history. Just to give some context, if we offer genetic testing to every single person in the world that's had a cancer in their lifetime, about 10% of the time that person would be positive. So there's a lot of factors to say, are you going to fall in the 90% category or the 10% category? If you have a super striking family history, I'd be more concerned you're falling in that 10% category, but it would be really hard for me to quote without seeing the family history and the other risk factors.
Right. So I'll take this last question. My father died of metastaticized melanoma at age 51, and my mother of melanoma at age 60. Are there anything that I should monitor with my primary care doctor?
Yeah, so definitely, and I'm sorry to hear that happened, especially from the same cancer. Melanoma is really a rare type of skin cancer. The first and foremost would be to get you to a dermatologist. They'll probably monitor you more closely because of your family history, maybe say go every 6 months or even every 3, depending on what they see on your skin. And then the other thing to consider is meeting with a genetic counselor. So we don't know too much about hereditary skin cancer risk, but there are some genes that would predispose you to developing melanomas more than we would expect. So, even though mom and dad aren't genetically related, at that time of the appointment, we'd ask, are there other skin cancers or other cancers in the family? And maybe that would make us even more concerned about something hereditary. So I always say it's worth a conversation with a genetic counselor. And in the meantime, independent of doing genetic testing, definitely get to a dermatologist and be monitored based on family history alone.
All right. So I think with that, we'll wrap up a few minutes early. Thank you so much, Stephanie, for giving this wonderful talk. If you do have a question, you can also email pflc@partners.org and we can follow up with you, but we will end this session here. So thank you so much, Stephanie, and also to the attendees.
Thank you.
Thank you.
We're talking about so I'm answering a question that came through a little last minute. Are there other genes than medically actionable genes that you suggest for testing? We suggest medically actionable and these preliminary evidence genes. We offer it to every single patient. It really depends on what cancer we're talking about. So there are genes in this preliminary evidence category for every single cancer that we talk about: breast cancer, colon cancer, prostate cancer, you name it, there are medically actionable and preliminary evidence genes for whatever cancer we're talking about. So yeah, we definitely offer both.
All right. So with that, I think we will wrap. So again, thank you so much, everyone, for joining and attending.